Good afternoon and welcome. My name is Carl Hinson. I'm the Director of Workforce Development for Hawaii Pacific Health, and I'm a member of the Hawaii Workforce Development Council. I have the honor today of moderating this discussion with our esteemed panelists. Their bios are located in your program, so please avail yourself of that and get to know them if you don't already. First, we're going to hear some discussion from Dr. Kelley Withy, who is the Director of the Pacific Area Health Education. Yeah, you do that one. I blew it. Okay, Dr. Withy, please.
But you owe me now, Carl, so I got one on him. So I work at the medical school, and I run a program that's grant-funded from Health Resources and Services called Area Health Education Center, which goal is to improve the distribution, diversity, and quality of the health professions workforce, which is a very large umbrella. But one of the things that I learned in doing this for 13 years is that if you don't know where you started, you don't know how you're doing. And so in 2008, with the help of David Sakamoto, who I saw here today, but maybe not in this room, we started a physician workforce assessment, and all of you that are physicians, you pay $60 every 2 years so that I can do this stuff. So I'm sorry, but thank you very much, because we're doing a lot of things to try and improve the workforce in Hawaii, not limited to just physicians, but that's what the mandate was for that. So the activities I'm going to describe first are what the AHEC and the workforce assessment, the physician workforce assessment monies are doing. But then I want to talk about where we're going, because the work of the Governor's Health Transformation Task Force is so important to this that without it, we won't be getting anywhere with relationship to physician workforce, because we're in a bad way right now. So you may have seen this slide earlier today. My boss, Roy Magnuson, used it. It was a little different than this one, but I can't complain because he's my boss, so I feel lucky he used it. But anyway, in 2010, we did the first workforce assessment. We found that we're about 600 physicians short based on what the mainland has for a population of our size and characteristics. Well, then in 2012, it looked like we were getting a little better, but that's probably because nobody was retiring because the stock market was so bad. And then this year, it came back to bite us. And so if you clean that slide up, this is what it looks like, and will be, if this keeps going, 1,400, 1,500 physicians short by 2020. So we don't want to do that. People always ask me, well, what's the breakdown? Half of the shortage is on Oahu, half of the shortage is primary care. It's not the same half, but that just gives you an idea about it. And you can see the neighbor islands are disproportionately represented in shortage, which is not a good thing, but that's the way it is. And so today at the conference, we're hearing about patient-centered medical home and provider teams, and that's awesome, and that's what we need, but we don't have it, because we did this assessment a couple years ago, and we're going to do it again next year. But when you take into account primary care, and you include primary care physicians, nurse practitioners, and physician assistants, we're short. We have shortages on every island. So we need to do multiple things to get to solve this shortage, and one of them is provider teams, but there are lots of other things. And I have a friend in Texas who also does AHEC stuff, and he says, we got to get them, train them, and keep them. And I said, okay, that's true, but I added a couple. We need to steal them, and we need to keep them happy. And so I consider that my job, making sure there are plenty of happy doctors in Hawaii, and other healthcare providers as well. So the things we do to get them. This is a teen health camp where some medical and public health students actually have a camp 3 times a year on different islands for high school students. And also they include college students and HOSA students. There's a lot of different resources, but they aren't all located in one site. So this is not a real website yet, but we're hoping that we can make something with this. And in collaboration with Department of Labor and KCC, we're hoping to be able to create and maintain a webpage where all the health careers resources are located in one place. So if somebody wants to go into any health career in Hawaii, they know where to go to get the experiences they need to apply, et cetera. And this is what Texas has. This is an awesome book. I'm so jealous. I know they're bigger than us, but why can't we have a book just as beautiful? So we're going to make one. We're having these conferences of everybody involved in pipeline activities. We had one on the Big Island last year, went really well. We have a listing of all their resources. It's not as big as they'd like, so we also have a listing of their needs. But we're gonna have them on Maui, Kauai, and one on Oahu, and then we're gonna have everybody together on September 6th of next year, and you're all invited. It'll be right here probably. And what we wanna do is make that booklet and that web page, have everybody proofread them, and then we'll be updating them regularly. So that's a goal. Okay, so train them. We train 76 medical students in Hawaii, 66 are at John A. Burns School of Medicine, and 10 are at A.T. Stills Doctor of Osteopathic School in Waianae, at the Waianae Comp. And we have about 95 medical residents every year. So some of these are duplicated, so we probably have about 120 docs that do some of their training in Hawaii. But even if we kept all 120 of those, we lose at least 50 docs a year, so it would take years and years and years to make up our deficit. So we know we need to do other things. But the good news is, okay, I know you can't read this, don't worry about it, but there are not that many things that Hawaii can say we're number one in. Sunshine, weather, aloha, things like that, yes. Beaches, yes, definitely. But in healthcare, you know, we've heard we aren't necessarily number one, but in this case, we are number one for keeping students who go to medical school and residency in Hawaii, 85% stay. So we definitely want to do this. That's one thing we know we can do. Okay, but we're probably at max medical school training right now. The good thing is we have a new family medicine residency program, which is interprofessional in Hilo, and they're going to take 4 students. They're going to take 4 interns starting next year. So that's really exciting because that will expand our capacity. That 95 number will go up to eventually, I think it'll be, you know, 110, 111 maybe. That's the AHEC mission. So now what we're adding to that is stealing them. And what well, it's hard to steal doctors because some of you probably heard in the HIT session we're short 130,000 in the US. Right now we train as many MDs as there are residency spots for. So that causes a problem because there's a bottleneck. So every state is in trouble. So it's very hard for us to get people here. And once we get people here, about half of them leave for different reasons within a couple years. So we have to work harder and harder to steal them. So a couple things we're doing is we sent out that postcard on the left to all the medical school and residency graduates from Hawaii. And we said, you know, we know you were here once, why don't you come back home and practice? And we have 50 now who said, I am interested. And so we're regularly sending them advertisements for jobs. And anyone can go on this website, they can advertise a job, or they can see what the jobs are out there. And this is an old version of what the website looked like, but it's in collaboration with the JABSOM Alumni Association, and we list any job that people tell us about for as long as they want us to list it. And we're hoping to make some matches that way. Okay, another way to steal them or keep them is to do loan repayment. And we're really excited to have a loan repayment program now. In addition to National Health Service Corps, which is a national program, we now have a state program, which we're hoping to continue. But we had 5 loan repayers last year. These are our first 5, the guinea pigs, as I call them. And we just named 11 more. And we have them on every island except Kauai. We really wanted to fund one on Kauai, but the feds wouldn't let us. But we have 7 of the, add them up here, actually more than half are nurse practitioners, and 1 is a psychiatrist, and 1 is an OB, and the rest are primary care physicians. So we're very excited to have that, and we hope to have that continue. But the legislature has to help us with that a little bit. Because it was started with HMSA and Queens money and some from Aloha Care, and then federal matching money. But that's going to run out. September 6th of next year, as I mentioned before, we're going to have the Workforce Summit, as opposed to this meeting, which is Hawaii Healthcare Summit. We're going to have the Hawaii Health Workforce Summit, and it'll be the 3rd one that we have, and we have national speakers, but we're going to do something a little different this year. We're going to incorporate parallel tracks. One for healthcare providers who want to know more about healthcare reform, payment reform, how to stay happy in your practice, and then a parallel track for educators and pipeline folks who work with students going into health careers. And we're going to have everybody together at lunch and then have a job fair actually for folks in the afternoon. So we're going to change it up a little bit. So it's free, so hopefully you will all get an invitation sometime mid-next year. Okay, so this is where what the healthcare transformation, the governor's healthcare transformation, and the SIM grant are so important because these are things that we can't do alone. We really need help, and these are the areas that you've heard about today. Teamwork. This is essential, and I will tell you a brief story. I was a practicing family physician until this February. I was in a team with a nurse and a medical assistant, and I loved it. I did it 1 day a week at a community health center, and it was my fun day every week. And most physicians can't say that, you know, it can be drudgery. But I'm not doing it now because both my nurse and my MA left, and I was bereft, and so now I'm looking for some new fun day, but as was mentioned at the lunchtime speaker, when you have that team, it's really fun. And when you don't, you got to find it again. So having teams make for lighter work, make for better care, they make for happier providers. So I'm all for patient-centered medical home, interprofessional training and practice. I think it's the way we have to go. Reimbursement reform, we heard about some changes, PCMH pay, pay for quality, bundled payments. They're all coming, and we need to understand them. But I know some doctors that are very happy with the changes, and then I know some that are frustrated with the penalties that are going to come in place. So we need to help people understand them and make them as painless as possible and as beneficial as possible. Administrative simplification, one of the other SIM grant groups is a multi-payer group where all the insurers, or most of the insurers, come together once a month and talk about it. And I've done focus groups with providers across the state, and the number one thing they said is, just get rid of prior authorization. Do you guys think that's a good idea? Yeah. Please, if somebody's overutilizing services, check them, make them fill it out. But if we're doing good, you know, just let us do it. You know, we went to school for a long time. So I'm going to be saying that over and over and over and over in as many ways as I can think of. I printed out all the prior auth forms that are on the web for all our insurers, and the stack is this big. So I'm going to take it to them. I'm going to say, this is what providers have to learn to do to take all your insurances. So hopefully they'll listen. Care coordination is absolutely essential, and you heard about it in more than one session today, but it's just so important, and I'm really glad that what the Governor's Healthcare Transformation Task Force is doing, and we probably need even more. We need care coordination for general care, for health maintenance, but then we need care coordination for the people who have the most challenges, and we all know that, and yet nobody really pays for it, so now that's going to change, I believe. Health information, absolutely essential. You know, you can't do this today without it, but it needs to be easy. We need quality metrics that are just pulled right out of your record. You don't have to jot things down. You don't have to calculate things. They're just pulled right out so you can see what you're doing. We need everything integrated, but we're not there yet. But we're trying to get there. And HHIE is helpful. If you don't know, they have a secure messaging network that you can get your results from specialists and hospitals. So that's exciting. And then telemedicine. We need telemedicine. We're an island state. We should have the best telemedicine system in the country, but we don't, so we're working on it. And so I have 1 minute, so I'm going to tell you about the goals, the ideas of our health workforce, our SIM group workforce committee. So we talked for a long time about different things, and what we came up with was, wouldn't it be great to have an early warning system so that we knew in 5 or 10 years that hospitals, healthcare provider offices, communities identified specific areas that we're going to be short of. They know there's certain folks that are retiring. For example, on Kauai, they told us right now we need ultrasonographers. There's no program on Kauai for that, but there is one on Oahu. So the next thing we need is and I will use our moderator's word here, a nimble educational system that can adapt to those needs. So why don't we take a group of folks from Oahu that are ultrasonographer educators and have them go to Kauai for a year and train them up? Or maybe have people come here. Why can't we do something like that? So we need to partner with communities, with industry, with academia. We need to get everybody informed, keep everybody talking all the time. And we thought a way to do this would be to have a center for all the health professions so they could keep all this information. I described to you the physician survey information, but have it all in one place. Take care of that booklet and that web page that let people know all the opportunities in Hawaii, but also have regular communication with everybody. Now, I know this is a complicated slide, but the idea is that we get input from, yes, projection models, but we know those aren't perfect, community, employers, and actually look at how many job openings there are. And then that goes to our group, and they work with the educational systems and create the nimble systems that will educate what we need. And then those are distributed where they need to be, and then that information is fed back. And we hope in that way that we can actually meet the needs before they get to be disastrous. And so we thought, and this is not anything official yet, it's just a thought, it's a dream, that if we had a workforce center, we could do assessment of supply and demand. We could work with groups that I mentioned. We could facilitate training all over where it's needed. We could provide feedback and get information, so information flow, and we could promote health career training as well as maintain all the pathway information so people could go one-stop shop for that information. Did I finish on time? Woo! Do I need questions now? No. Okay, good.
Okay, at this time, I would like to introduce Mary Boland, who is the Dean of the UH Manoa School of Nursing and Dental Hygiene.
Aloha, everyone. Good afternoon. I talk fast, but not as fast as Kelley, so you have a chance to catch your breath. But I'm delighted to be here with you. I've had the privilege and the honor, I think I would best say it, as serving as the Dean for Nursing and Dental Hygiene at Manoa since 2005. So it's been a wonderful experience, and I think being in Hawaii over these last few years of healthcare transformation, it's amazing to see the differences that are happening as we speak. Every 3 months, I'll go to a different meeting, and we're clearly transforming. We're not where we want to be, but we've taken those steps on the journey. So for us then that are the academic educators, and I'm part of a larger college that is at Manoa, so we have JABSM, the School of Medicine, Nursing, Dental Hygiene, Social Work, and then Public Health. And when we come back, and our challenge is always, how do we get you the workforce that you're going to need? Right person, right place, right time, right skill set. It's a huge challenge, partly because the U.S. system is very generated by the students and their interest. The good news is that there are lots of students in Hawaii for all of us, many, many more people interested in healthcare than we actually have the capacity to admit, whether you're talking about the community college programs or Manoa or the medical school. So I'm very comfortable that we have a large number of extremely well-qualified students who are interested in health. The challenge for us always is, how do we bring them into the system? And then do we give them the right education? Because we're publics, right? The medical school is part of the public. In addition to Manoa, we have 2 private nursing schools, Hawaii Pacific University and Chaminade. They both offer bachelor's degrees. HPU offers master's, but Manoa is the only place that offers master's, DNP, as well as PhD. And so not only are we educating providers for you, we're also educating educators for the rest of the state. So it's very challenging given the fiscal climate we've been involved in. We have great faculty. They work hard. We get wonderful grants. We are finishing up a 2-year grant from HRSA. We'll be graduating in May. by August, 14 advanced practice nurses, people everyone's been cheering on today, but 14 of them ready to do primary care in Hawaii, from Hawaii, committed to working in rural underserved communities. But that will end, and then we have nothing for the students that are currently enrolled. So it's a big challenge. What I'd like to do then is talk to you a little bit about where we are in terms of the state, and then just see if we can move forward a little bit. There's been a lot of work done on how to build a primary care workforce, so I won't bore you with that. Hawaii is great, as we all know, about talking about things and the nuance and understanding them. So we define primary care workforce, any occupation that provides or supports health services. So that's everybody from your MA all the way up to your physician. We have a plan. We have the 2020 Plan for Workforce, a report that came out 2011. We want to increase our workforce 20% by 2020. And then Healthcare Transformation out of the Healthcare Project has had a workforce development committee that's also been looking at how do we move this forward. So what do we know based on this? Well, we know that medicine and nursing have shortages. However, when you disaggregate, we see different things. We don't necessarily have an undersupply. We have a maldistribution. We have too many of some, not enough of others. At the moment, we actually have a surge of new nurse graduates. We have bachelor's prepared nurses who are not able to get employment as RNs. Much of this is due to the economic challenges from the recession in 2008. Many of the nurses are choosing not to retire, or I shouldn't say choosing, they don't have a choice, or not retiring. And so the jobs that were projected based on the best modeling that we have not emerged for people. And so we have a big backlog of RNs really ready, willing, and able to work. Many of them do not want to go to the mainland. We've been forced as educators to say to them, go to the mainland, come back with a couple of years' experience under your belt. You'll be much more hireable. Yet at the same time, many of the acute cares and even some of the long-term cares are bringing in traveler nurses from the mainland because they want specialized skills and they can't necessarily afford to educate, or their need might be time limited and they don't want to invest in somebody that they're going to have to let go in a period of time. So it's very challenging trying to work within the nuance of today's system. When you look at primary care, you've heard it all through today, so very little for me to do other than to reinforce that APRNs or MPs, depending on what you call them, can deliver primary care as well as some specialty care. And I would say increasingly acute care, and I'm going to show you some data about that in a minute. So I think our challenge is we've had a system that has overly relied on physicians. We sort of have nurses kind of ready, willing, and able moving in to those roles. Best example to give you, right, is the old blood pressure. There was a time when only the physician could take your blood pressure. Now you buy your blood pressure cuff online and you're taking your own blood pressure and you're submitting it into your provider. So this role has really evolved. We've got very good evidence data. There's no question about it. But we're also very tied to these very specific roles for physicians or for nurses or dentists, if you want to think about it. But there's some interesting literature coming out, particularly an article this month by Tim Garson, who's a former medical school dean at Baylor and UVA, and who's really saying maybe we don't need as many MDs and nurses if we build our systems better, if we leverage each member of the team, and if we include the patient and the consumer. So any of you who went to that patient-centered medical home session that preceded this, you heard that loud and clear, two very different practices, but already seeing the results of just thinking differently about it. So it's great to see us considering a range of approaches. The question then back to us as educators is, how do we help our students to learn? We want them to learn in innovative sites. If you look at APRNs in Hawaii, this is the number that you see on the slide here. Contrary to what you've been seeing and everyone else showed today, we're not dropping. The number of APRNs is actually increasing. And the number of APRNs who can write prescriptions, including controlled substances, is increasing as well. When you look, though, by island, you see the same thing everyone talks about at any meeting you go to on healthcare delivery in Hawaii. We have reasonable numbers on Oahu, but once you leave Oahu, you see a steep fall off in terms of what's available. Hawaii Island is next in the number of APRNs, followed by Maui and Kauai. Some of the reasons historically that Maui and Kauai don't have APRNs, I'll be quite candid with you, and my colleagues sitting in the audience from Maui College will tell you, up until this past year, and the only nursing education available to a nurse on Maui or Kauai was an associate degree. And what the associate degree did was it just topped you. There was nowhere you could go, because to become an APRN, you need at least a bachelor's degree or come in as a second career student. So there were a lot of capacity on Maui in nurses, but no way for them to get the credentialing to move up. We've changed that at UH. As of last year, we graduated 12 students from Maui and Kauai with bachelor's degrees via an innovative model that the faculties and all the islands work together to put together. So they do 3 years at the community college, 1 year with Manoa, but offered in their home communities, and they get a bachelor's from Manoa. So we're really excited about that, because if you don't have bachelor's people on the neighbor islands, you can't have APRNs on the neighbor islands. And we're seeing some of those students go right and enroll directly into graduate education to become APRNs. And then this is really telling. Look at where your APRNs in Hawaii work. You would think most of them would work in primary care, but they actually don't. And this slide is courtesy of the Center for Nursing. Fair number of them are teaching in academia. They're not teaching in APRN programs, though. They're teaching undergraduate students, because up until about 2 or 3 years ago, there wasn't the workforce demand for them. So they were teaching, maybe practicing a day a week somewhere, but not necessarily fully engaged. But you can see ambulatory care makes up a very small number. And guess what? They're migrating to the hospitals. Hospitals are really using them now as in the context of the hospitalists, or Kapi'olani, neonatal nurse practitioners, Queens, neuro ICU, subspecialty, because again, their skills and expertise can be developed. And then you see very small numbers of them, but increasing in physicians' offices. And very few in school health, because we don't have school nurses in our Department of Education. And so they aren't going into that employment either, like they might in other states. So the question then becomes, how do we address this? Well, we're very fortunate in that we have what is considered a Model Nurse Practice Act by the rest of the country. Whether you like to hear this or not, the people from Long CVS Minuteman clinics came to visit us when they were starting to plan. These are all nurse practitioner-run clinics. And we said, well, why Hawaii? Why now? And they said, well, because of your Nurse Practice Act. We don't have the time. We're not interested in changing Nurse Practice Act so these nurses can work. You've got the act. We're going to employ them. And I think that makes us very progressive in terms of how people look at us and our ability to attract. We've increased enrollments. We have no trouble filling the spaces that we have for APRNs. There are nurses out there who want to be APRNs. We've also put in a statewide BS nurse residency program, but it focuses on acute care. We're using a model that is being used across the country that gives nurses 12 months to transition from their bachelor's program to being a really, if you will, beginning competent, mature nurse. And it's turning out to be very effective. All the major hospitals in the state are involved in it. They're seeing wonderful, wonderful results from it. But we have no primary care residency, either for a new nurse, a bachelor's nurse, or an APRN residency for our new nurses. And I should say many of the APRNs coming out that will be graduating are new nurses. We have at UH Manoa what we call Master's Entry Program. It's very similar to a medical school model, but you have a bachelor's degree in something, anything. You do some prerequisites, you come in, As a graduate student, you get an intensive one-year experience that allows you to sit for your boards, to be certified or to be licensed as an RN. And I'm very proud to tell you last year 100% of our graduates passed on the first time. But they don't graduate, and then they go into their subspecialty tracks. But what that means then is that when they graduate as APRNs, they're not the ER nurse with 10 years of experience who's gone back to school or the nurse in your office. They're brand new. So we want to think about how can we, in fact, encourage them to really stay in the state and become competent practitioners. So in terms of background, I just want to let you know, when we think about a residency, this is not something we invented here sitting around on the beach one day, but there's a lot of experience across the country on it, both in acute care settings as well as in community health centers and other primary care settings. So what we're proposing and what we hope will make its way into the next grant that goes to CMS for innovation is to expand the network of clinical partners, particularly in underserved and rural population centers, to work with not just UH Manoa, but UH Hilo and HPU. We want to really improve our clinical placement process. We want to increase the quality of the clinical training our students get. So we're talking about then a 12-month residency program, intense clinical training, community health centers, federally qualified, with the schools, with any of you in private practice that might be interested in it, different settings, and then in addition to the clinical experiences, the students will have access to and work with their colleagues via the College of Health Sciences. So JAPSOM will be involved with this. The students will be working with physicians as well as social workers, understanding population. We also have the business school and the law school available to us. And what we're hoping at the end of that 12 months is that you will have nurse practitioner for your practices, your patient-centered medical homes, who is really skilled, committed to you, building to improve patient care. So this sort of talks a little bit more about what I said. We'll be doing some pre and post-residency competency assessment. A lot of the support, again, will come from UH. Students will rotate. We would love to see positions funded for 20 residents statewide, 10 BS and 10 APRNs, because the BS nurses coming out of school right now don't know patient-centered medical home. You don't know it. You're just starting it up. There's no way for us to give them clinical. We've got to get them out there, helping them to understand from your perspective what it means for your practices and your centers, as well as having APRNs. And if we're able to do that with a model like that, we have a real advantage, I think, in terms of improving access to a sustainable primary care workforce for you. And I'm sorry, I had one slide that I had a couple versions of this, and maybe I went over it, but the numbers of students that are enrolled currently today, as we sit here, in primary care APRN programs in Hawaii are 159. You've got 22 over in Hilo, and you've got the remainder on Oahu between Manoa and HPU. So those are primary care workers. They're your partners in all of the changes that are happening. They're committed to this island state. They're willing to stay here for a long period of time, if not their whole careers. The question is, can we feed that pipeline for you? So in my mind, it's a piece of very good news. We hear so much doom and gloom happening, right, around where we are with the workforce. But we're really delighted to say that we have people that are enrolled. Via this HRSA grant, we have 14 of them graduating by the end of the summer, adult geriatric nurse practitioners who have made a commitment by taking their traineeship money that they will work in Hawaii and in underserved and rural communities. The question is, can we bridge them from the academy into practice in a way that nurtures them to become not just technically efficient, but also compassionate professional care providers, capable of really being partners in the healthcare transformation that we will see over the next decade. So thank you very much for listening.
At this time, I'd like to introduce Patricia O'Hagan, who's the Dean of Health Sciences, Emergency Medical Services, and Nursing at Kapi'olani Community College.
Good afternoon and welcome, and thank you for staying to the last talk. How many people are from the neighbor islands? welcome. I'm glad you're here. It's good. It's important. We need you as our partners. So I want to start at the high level of this talk is that to really redesign Hawaii's healthcare workforce, we need to focus on the social determinants of health. That might sound odd, but if we're really going to change the workforce, we need to expand how we train and where we find jobs. And we need to start looking at it from a team perspective. So I asked you to cast your minds back when you first started out. How many people started out in healthcare? How many people actually started out in healthcare? How many people are in the same job they started out when they left university? Not that many. How many moved into healthcare out of a passion and a desire? A few more. How many did it because of the money? Very few. Okay, so I want you to think about transformation in terms of capacity building and looking forward. So cast your mind back to the beginning. And what we're really looking here at are career pathways. Where were you? When you walk through this with me, think about your own career path, how you started and where you are now. When you were in high school, what did it mean when you left and you began your career? When you entered college, did you enter directly or did you go get a job? Did you go in and out of college? Did you have a part-time job? When you completed college, did you go back into the workforce or did you go on to university? I want you to think about that both for yourself, your children, your community, and more importantly for Hawaii's workforce. Because that's who these people are. They're individuals stepping through a career trying to find their way. So who I'm addressing are all of those allied entry-level workers who someday may become a doctor or not, who will stay in Hawaii's healthcare or not, but it's incumbent upon us, because they're putting their passion, their money, their energy into being educated in healthcare, to keep them in that pipeline. So removing the barriers. First, we need to address the academic skills that require students being in multiple semesters because of coursework trying to find out what it is they want to do. That not only affects their financial aid, but it affects the number of years they're actually in school before they get into the workforce. So we need to connect them to their passion, and we need to find it out early. We need to choose the right courses for their pathway. So we have to have educational plans. We need to connect them, as Kelley mentioned, to transfer and employment centers so that they know what the jobs are, not at the end of their career, but the beginning of their career. Really, what does this look like? We need to give them the long-range plan of what they're looking at. And we need to develop a sense of belonging. This last point I want to tell you something about. We did, for the first time in quite some time, an analysis of why students come to Kapi'olani Community College. We are the health science center for the undergraduate programs, and the number one thing that students continually said was the counseling faculty that take them through the process. We just did our ADN accreditation. We were recommended for 8 years of accreditation, and the number one thing that the site visitors commented on by the hospitals and by the students was the counseling, the support the students got, so they stayed in the program. So we need to create that sense of belonging in all programs. We need to have it in the workforce as well. You don't just let someone loose in the workforce and not have a mentoring program. So, the healthcare programs, in a nutshell, at Kapi'olani Community College, there are prerequisites. They're basic, but they're a requirement that someone out of high school may or may not have the capacity to do. The areas that they can choose from are nursing, the emergency medical services, which is a basic EMT or the paramedic program, and 8 accredited health science programs, and you'll see the list of them coming up. All of them have national and state certification exams. So jump forward to the panel, what the skills panel told us. They want us to focus on nursing, primary care, technical disciplines, long-term care, and workforce readiness. That is what we're trying to build into when we're looking at the social determinants of health and community development. So what are the strategies that we need to do? 1, we need to connect workers to better skills, the jobs, and the opportunities. We need to develop a plan that meets the long-term needs of the industry, And we need to track that data of meeting the employer's skills, both for efficiency and less turnover. And finally, we need to communicate between employers and educators. It's a two-way street. So what's the industry look like right now? This is the employment data from BLS, and if you look at the numbers of the percent changes, you will see a lot of offices of physicians, home care services, office of dentists, office of other health practitioners, and then diagnostics. That's where the growth is right now. If we're really going to focus on the social determinants of health and change the workforce, we got to start looking at community. All of our programs have been focused on acute care. There is a reason for that. It's because accreditation requires skill development in acute care, but that shouldn't be the only place. We should be looking at prevention early in life and treatment of post-acute care and long-term care. So here are the programs currently offered: occupational therapy, physical therapy, exercise and sport therapy, massage, dental, radiology, medical lab assistants, and it goes on. So I'm going to just list them. What I want to note for you to note is the right side. That's community. All of these folks, while they may be in critical care, office, labs, and physical, aren't focusing their training in the community. While they may do parts of it in their training, it's not part of the rubric of assessing outcomes. So what have we learned? We learned that education needs to be linked with experience and expectations. We've learned that mentors and counselors matter a great deal in success and completion. We've learned that simulation mannequins really do address the step out to clinical practice because of the squeeze in acute care. But not only that, it adds a level of assurance to the skill of a young, new entry person by practicing on simulation mannequins. We've also learned that the team approach is the way to go, both in clinical and field work. We try in our training to have the nurses work with the respiratory care therapists, the respiratory care therapists to work with the medical lab assistants. If we're going to do it in education, we should be doing it in the clinical setting and in the field work. We shouldn't be sending respiratory care out one day and nurses out another day and radiology out. They should be going in as a team. So the cost of living. Now I want to put Hawaii now into a context. This is the data of the cost of living index in Hawaii as of a month ago. And you will notice there are very few cities, rather large urban cities, where the cost of living index is higher than Honolulu. New York is lower. Sydney is higher. London is slightly higher. It's a very expensive place to live. So when we think about job training and transforming jobs, we need to be mindful of what it costs to live in this state. So our nursing department, for example, here are some of the programs and the average salaries. So an adult residential care program makes $41,000. A long-term care nurse aide makes $12 to $15 an hour. That's entry to experienced. An LPN can make up to $53. An RN can make up to $80. And then what we want to do is pathway them into postgraduate education. So think about that in terms of the cost of living. Now look at this annual mean income, and this is just for support care workers, and you can get the same slide for practitioners. Hawaii is in the upper end of the wage for support workers, but still it's in the lower end of that upper end. So that's a very interesting slide just to show that while we're comparable, we're not at the highest end. So where's the need? Again, I ask you to cast yourself back to high school. Did you know what you wanted to do? If you were interested in healthcare, what did you do? Who I want to target are those high school graduates who are undecided but interested in healthcare. So here we have a context. Look at our figures of our public schools. We have 286 public schools, 254 DOE schools, 32 public charter schools. Our enrollment is about 183,000 students in K-12, and we have 13,000 teachers. Then we have our school health aides, bless them. Where most programs of school health aides are addressing physical health and the well-being of your students. How many of you have children in school who have been assisted by a school health aide? Anybody? Do you even know? Okay, so they are our prevention and our early warning. They are, and yet, they have a high school diploma, they are certified with CPR and first aid, and they are making minimum wage. And they are our early health care for our young people in this state. Let me show you something else. Look at the comparison of their salary. A job ad for someone in San Francisco who's a school health aide makes 97% more than a school health aide in Hawaii. That's as of October 30th. It's a dead-end job with no pathway, with minimum wage, and we need to change that outcome. So, the proposal here that I'm hoping we can do is change the skill level. What we know is a certificate program, speaking about nimble and reacting to, is a short-term program that addresses specific skills and knowledge for a specific position. Now this might seem, the next point might seem very minor to you, but a high school diploma earns $5,000 to $7,000 a year less than a diploma from college. If you put that in terms of young kids wanting to buy a laptop, a high school student will take 3 to 4 months to save for that versus a college student who will save it in 1 to 2 months. That's half the time. So, a new pathway. We need to create a pathway. We rewrite the curriculum. They can pathway into any number, but the most obvious ones, because there's another need, is the community health worker. And the fastest growing currently, allied health, is a medical assistant. So there's 2 potential pathways for them. We need to have a certificate curriculum that's recognized by the DOE. We need competencies, which we are working with right now with the Department of Health and the DOE, to update the current curriculum that's there. We need field practice so that those students go into the schools and actually practice what they're learning, just like a nurse does when they go to a clinic. We need simulation mannequins, which I've written a grant for, that every college in the system will have access to for this program. We need electronic student health record to be implemented. Right now, everything's done by paper, but there is a system sitting in the schools waiting to be used. We need sustainability reporting and oversight. So we need to increase the salary, we need that pathway, we need student tracking of records, and we need a reporting mechanism. Mary just spoke to the nursing issue. There is a place for nurses and DNP to oversight to make this a sustainable structure within the state of Hawaii and create a new career. So strategically thinking, we are actually delivering this through all of the college system. We have certification that can be recognized. It aligns with a gap in the workforce. It demonstrates flexibility in short term. It offers a career path forward for those high school students who have a dead-end job, and it meets the goals of a number of different groups in the state. More importantly, it also can help define new leaders. When you are a healthcare student at Manoa, at the colleges, in any of the private sectors, you can join HOSA. This is a leadership training place. If we bring the school health aides into the system, they can become new leaders. These are gold, silver, and bronze medalists from the last year who competed in Florida. I can tell you that some of the colleges beat out the 4-year students. Finally, next year is the 50th anniversary of the community colleges. 50 years of health, 50 years more. We're going to have a community career fair. Students from all of those skills will be demonstrating them. We're having 1,200 high school students. We will bring the school health aides. We will have veterans, and we'll have encumbered workers. What I can tell you right now is that there's 253 school health aides in dead-end jobs. 89% of them are employed. 12% are in vacant jobs, and they have nowhere to go. It is incumbent on us, and it's one example, it's incumbent on us to change that need, to help us expand into community work so that we can address both the social determinants of health and have a flexible, healthy school system. Thank you.
I wanted to come up here and say, have you ever seen such passion in your life? Not just from Patricia, but from all 3 of our panelists. They're very passionate about making sure that we've got the workforce that we need moving into the future. So start thinking about your questions. I'm going to ask a question to get them warmed up for you. but certainly feel free to come up to the microphone. Any questions you want to ask. I think we have a few minutes left. I look at my timekeepers and they're not paying attention to me, so that's okay. We have a few minutes. So let's start off with what I think is a relatively easy question that our panelists can take a stab at. We've heard earlier today that over 50% of our physicians are dissatisfied with their profession. So along the lines of Kelley's discussion about make them happy, what else can we do or should we be doing to improve the career satisfaction so that physicians will not only stay in the career, but stay in life?
Well, you got a few hours. One thing is to make the environment much friendlier to them. And I'm sure any physician in this room knows that there's many ways to do that. If you're in a large group, you have a supportive infrastructure, and so if you're not in a large group, you need to create a supportive infrastructure somehow, and that includes teams, that includes partnering, that includes independent physician associations, whatever it takes to have the support that you need in your office. Pay is always good, and pay for performance is better than the rat race of getting paid for the number of visits you have, which makes no sense. And then I think teaching is actually rejuvenating in itself. So having students working with you in your office, I think is just makes you feel more on top of it, or not, and makes you get on top of it. But I just think contributing back, and then also appreciating the community and mutual appreciation, because that's one of the nicest things for a doctor. And whenever I talk to a public group, I say, there's one thing you can do for your doctor right now, and that's say thank you, because that's why many of us do it, just for that connection. So that's a few things.
Thank you. Come on up. I don't have to ask any questions.
Actually, my comments are addressing your question, so
Okay.
I wanted to add on to that.
Good. Oh, you should have just answered it.
It seems to me that it is important to improve the workforce, both for physicians and all the other healthcare professionals. But it's equally, if not more important, to make sure that of the ones we have, that there are enough that are willing to see Medicaid patients and work in underserved areas and in rural areas. And if you train more doctors, but they're not willing to do that, you haven't solved the problem. And along those lines, I think that the first requirement is you have to assure appropriate pay for the training and skills necessary to do that job. And I'm maybe going against the grain on this, but I think all this pay-for-performance stuff is a waste of time. If you assure a primary care doctor that they can make $250,000 net, you don't need all that stuff, and it's very expensive to do pay-for-performance. Just make sure that they get the appropriate pay and rely on their professionalism and their desire to do the right thing for their patients as the basis for your quality improvement. Instead of pay-for-performance, we could save a whole lot of administration, make their lives much simpler, eliminate all the need to game documentation for payment purposes, and the second thing is you've got to make it simpler to practice in rural areas. You can't have it be this complicated. That's what deters people from going to rural areas. If the payment structure is simple, if they know that if they go there and see the patients they're going to get paid, you don't need to do all this fancy, expensive stuff. And they'd be happier for it, too. You need teams, you need the community outreach, you need the physician extenders. All those things improve practice satisfaction. You need cross-coverage arrangements so that they don't feel isolated and never get a day off. And the last one is from Leslie Guys on Maui, which is give them surfing lessons. The ones that become surfers stay in Hawaii.
Thank you.
Well, I wanted to commend all of you for very passionate presentations indeed. This actually goes to Dr. Boland, a point you made, and I'd like to be able to hear from all the panelists. You quoted, I guess, or mentioned an article, I guess, by Tim Garson, I guess, regarding the need to leverage resources, and it really got me to thinking, because I know on the neighbor islands, and I work for Department of Health, so I'm concerned with coverage for not only Oahu, but really all of the neighbor islands. Do we need to look at really more how we leverage the resources we have? And along that line, to what degree does care begin shifting more to the patient or consumer? Because I know, for instance, like for someone who sees a physical therapist, a lot of times that physical therapist gives homework assignments for the family to do. Or if it's a nurse or a physician, they may say, to what degree do you monitor your blood pressure versus coming into the office? And I'm just wondering if maybe that's the paradigm shift we really need to be looking at, because it almost sounds like if we keep trying to train and produce more and more and more, I don't know if we're going to meet the need. And so is it a question more of leveraging the resources we have, training those practitioners that can be the early warning, your paraprofessionals, your LPNs, I mean, all of those. So comments, if you would all, please.
Sure. I'll start then. We have to be willing to be open. And I think that's the challenge for any of us who came up in what I call sort of the golden age of the professional. Didn't matter what professional you were, right? But you were gilded, you had your title protection, you know, only you could do whatever it was you were gilded to do. And I think what we've seen and why we have healthcare reform is that that system just was ineffective. But the challenge then is moving from that to be sure that you have some quality, right? So if you're in Department of Health, that probably sits on your doorstep every day. But that said, I think that willingness to look at this, Pat's presentation, for example, around the school health aides, I'm guessing that some of the things they'll train those aides to do 10, 15 years ago, only a nurse could have done. Now a health aide can do it. So I think we have to recognize the needs of society evolve, and we've got to be willing to evolve with them. And it's a big challenge for us. The piece on consumers, though, I think that's happened. That's happening. You know, when in the previous presentation, again, once you get an app for your phone, you're there. My Health Advantage, this is not a plug for Carl, but my
Thank you.
Yeah, but after, quite honestly, some highly unsatisfactory encounters with medical providers in Hawaii, we moved to the HPH system, and we are their most satisfied customers. We're their poster child. We both have our apps. Granted, now I'm probably a little more sophisticated. My husband is not. He hates anything to do with healthcare. He's your classic chronically ill older person, you know, very functional but needs management to stay that way. And he, I mean,
being recorded.
Yeah. He would say it to you. And he's on it. I mean, I just cannot believe the difference it's made in terms of his. So that's one little anecdote. But I think we're seeing more and more consumers. They can't avoid it. They also recognize, because of the errors and the errors of omission commission in healthcare, that they've got to be on top of it, right? So it's there. The question is, are we going to be ready for them? Because any practice or group organization that pushes them out or tries to do this to them, you're not going to survive in this environment. It's very much this and this. And I think that the challenges that we're all facing is how to get providers out with that skill set. I'm very optimistic, though, with the new generation. We know even from the data on sort of the newer generations, they like group work much more. They're much more electronically connected. They're not so caught up on who's who. So I think that we do some education, med students and nursing students that spend 3 days together their first year. And we're finding that they come in with some preconceptions, but they're very easy to remove. And then they start to know each other and work together. So I think those are the pieces we have to do. Challenges are we've got these old laws and regulations that just get in the way of it. Because I know Carl's going to ask me eventually, right? What's the barrier to full APRN utilization in Hawaii, right?
Stole my question.
See? And I think there's two. One is federal, so it's going to be a little hard for us locally to deal with it, and that's CMS and reimbursement. But the second one is obsolete regulations, not statute in Hawaii, but regulations across multiple departments, Department of Health, Department of Human Services, DCCA, that say physician. And if it doesn't say physician, no one else can do it. So we've got to get some legislation through that's more omnibus, because the departments are all busy. I don't disagree with them. I don't like it when people add things to my plate. But if they're not willing to move up and make the changes, then legislation is going to have to happen to push the regulatory stuff onto them. So that was a long answer to a short question. that.
I don't think I need to answer.
I'll just add two things. The team is essential. I can tell someone to quit smoking, but I can't spend an hour with them a week talking, counseling. And then also rewarding the patients, and this is happening in some other states, but, the doctor can only do so much, the healthcare provider can only do so much, but, if you get a bonus for quitting smoking or bringing your blood pressure, blood sugar down, maybe that'll help.
I guess I will add one thing then. If we get the teams of allied health workers, for instance, into long-term care settings and the schools, we start educating our population. They expect the information. They expect it to be. They become our partners.
Our last question.
Okay. In the 90s, I worked with an organization, Keolo, Hawaii, which was, social work, nurses, medical students, public health, being trained together in the health centers. But also there was a pipeline attempt with the high school kids. We used to bring them up to Manoa once a week. It died. Why? No one could pay for the bus.
It's true.
The bus. Now this is the, the second or third largest industry in Hawaii, and the industry would not, or did not, or we didn't ask, or whatever, could not pay for the bus. And in fact, the whole Keola pipeline thing kind of just collapsed when the grant went away. So my question is, are you hopeful in this time of transformation that the third largest industry in Hawaii might be able to pony up some of these funds for the bus, for the multidisciplinary training, and not just expect the educational world to do all the funding?
I think that's a question for Carl.
I knew that was coming.
Take it away, Carl.
Actually, I can stand here and tell you today, the industry is prepared. The industry is stepping up in ways I don't think we have ever seen when it comes to supporting our educational partners, making sure that we're removing some of those barriers ourselves. So, she said it as fast as I was saying it to myself, but I'll pay for the bus.
And he does.
And I
he
do.
He does. HPH spends what?
We're fortunate that we've, we work for companies. Queens is just as generous. Our healthcare industry partners across recognize the needs and are stepping up and doing what we can do.
But I want to add to Jim's comment, though, because it's very critical. That was a wonderful Kellogg grant that you're talking about, right? But it wasn't sustainable. And I think what we're looking at, and this is maybe how we've all matured, industry and education, they've got to be sustainable. They've got to have either ways to generate revenue or have ongoing funding streams, because exactly what you described is what happens if we're not doing that.
Well, thank you all very much for coming, and I'd like to thank our panelists for their presentations. Thank you. I believe we've got about a 15-minute break before the next session in the main hall.